Hello, everyone. I am so excited to be able to speak with Dr. Greg Lehman today. I have been a big fan of your work for many years. It has helped both myself clinically and my patients. And I'm very excited to introduce you to all of our people on this call. You are a clinician, a researcher, a clinical educator, I believe both a PT and a chiro. You practice in Toronto. So just to give us a little bit about yourself and, you know, kind of the things that get you excited.
Well, that was it. You nailed it all. Yeah, I'm in Toronto. I think I'm only excited about golf now. That's about it. We've been golf because we're just coming out of winter, so I want to play. Uh, I'm so yeah, I'm primarily a clinical educator now. Like I still have my practice. We're moving, so I think I'm making my practice go all 100% online.
Yeah.
Like I have a tiny little clinic that I practice out of that's in my house, but we're moving. So my clinical practice will be all online soon, I think. I'm a bit excited about that.
Yeah.
That'll be good. And then yeah, I go around and teach like everyone else does, which is fun. I've been doing that for 10 years. And it's neat. I had like a message that I was saying 10 years ago that wasn't that popular. And now I've seen like it be a lot more popular. So it's changed. I'm a bit excited about that.
I think right out of the gates, you talk about seeing patients online. And I think like years ago, we would have been like, how do you even do that? But I
Oh
think so
yeah.
much of what we do now is education that you can see really good results seeing people.
Uh-huh. Yeah, I'm with you. Like, so 10 years ago, I would have been practicing way more manual therapy, and I had to, and people expected that. And if you didn't do it, like they would be like, what's the point of seeing this person? But I always found, uh, even then, what I knew was helpful was the exercise or the advice and talking to people and validating them. You just had to do the manual therapy because people expected that. Right. So now it's weird. Now, when people come and see me in person, we can just talk and plan, and it's coaching and all of that stuff. And it's great.
And it
So
goes along.
yeah. Yeah. And so now, like the online model just makes sense. I couldn't have done it 10 years ago. There's no way, though. Yeah.
So to give an intro of kind of your approach to treating your patients, um, reconciling biomechanics with pain science, can you just explain that concept and what that means to people?
Yeah. I think so. It's a bit of a reaction to the classic kinesiopathological model of injury, which would be like, oh, your knee caves in, so there's too much load on the lateral patellar facet. That's why I have knee pain. Or it was very postural, structural based, and all these things. Or the say with the spine, the multifidus isn't firing. It was all set up, and and I never really bought into those ideas, but I never discounted people's interventions. Like I thought, oh, I know Paul Hodges is still helping people by doing multifidus and transverse abdominis training. I just never thought that there was an issue with the timing. I would look at it and I would think, well, if I turn the sound off and just watch this person practice, what are they doing? And I thought there's still lots of good in there. So like a classic motor control program, if you really look at it, it's just slow graded loading, getting comfortable with your body again, reintegrating these basic local loading with big meaningful activities or things like that. So it was all saying like mechanics are still important, just maybe not how we think about them. Right. And then it should be integrated with pain science, which is just short form for like the biopsychosocial, that pain is more complicated than just
Yeah.
simple tissue stress.
I like how you use the term it's multidimensional.
Yeah. When it comes to pain, everything could matter.
Yep. I
And
think
and that doesn't mean it's just in your head. That means it's like biological. Like if you're stressed and you're not sleeping well and you're worried about things, that's not sure those are psychological things, but they influence the biology of your system. It's an ecosystem.
for sure. I'm currently taking your running resiliency course, which I love.
Oh,
Uh,
good.
it's really good.
It's too long.
Um, I like long. I'm a detail. I love.
See, I wanted it to be 4 hours, and then I was like, I think people want more, so just added stuff and repeated. I'm like, there's probably going to be people that just need all the extra information, but it was
I
meant
like
just to simplify running.
the chunks are like, there's little like 10, 15-minute chunks. And I think that's a good,
Yeah, yeah,
piece to it. I think in the foot world, because we a lot of foot and gait people, I think there's really no other arena where you hear things like, our patients all the time. I have flat feet. I'm a pronator. I'm a supinator. I've been told my arches have dropped. And it really, just when the patient walks in the door, we're already like needing to have these conversations. So what I thought would be fun is I have a case study that I wanted to share with you, and
sure.
I would love to know what your approach would be and your communication style, because that's where I get caught up. Because my first reaction sometimes is, what the fuck? I don't even know
Yeah.
where to start. So this kid came in to see me. He was 27 from Reno. He was a quadruplet who I've never seen a quadruplet before.
Oh, okay.
Just siblings. A couple years ago, he was training to be a wildlife firefighter. So he wasn't very active to begin with. And then he started, more time on his feet, hiking, load, backpacks, things like that. Started experiencing foot pain. 2 years. So this had been going on for 2 years. By the time he came to our office, he had been out of work for a year and a half. He had gone, to see multiple people that have been told just those things. Flat feet, weak glutes. You name it.
Yeah.
And the last clinician that he saw was a well-respected podiatrist who had told him, and this is 2 years into his pain, that he wanted him to decrease his step count to 2,000 steps a day. So
Oh,
take time off his feet. So for the last 3 months, this kid has been in his basement, literally afraid to go to like 2,010 steps.
okay.
So now he's depressed. He's anxious. He's seeing his 3 siblings like enjoying their life. And he's telling me all of this. And I have so many thoughts. I just want to know from a community, like, where do you start? What are the questions you would
Yeah.
ask? How do you start there so that you can make like a profound impact with your initial kind of work?
Yeah. I would add like, I almost sound like a psychologist, but it's um, like I always ask, what do you think is going on? Right? What do you think the problem is? What have you been told the problem is? And related to that, I'm like, okay, well, what would success look like for you? Like, what does your life look like 3 months from now? If we work together and you're doing amazing. Right? Like starting with the end goal. What is it that you really want? How can I help you do that? Right. So then get that idea of what their true goal is. And then asking, well, what do you think you need to do? And that simple idea, because so this is why I ask that, and why people ask that is like often they know what they need to do, right? They just need help doing it. And then sometimes you can just focus on that. All right, good. Let's run with that. Let's do those exercises. Let's do more walking. Let's do the firefighting, whatever you have to do, and build you up to do that. But then you might find that this is maybe what you're heading toward is like could have some really unhelpful beliefs about his feet and his back and everything going on. And then you almost have to make that call. Is that belief that he has, like, is it a barrier for his recovery? And then it's worth talking about. And then I'd be like, so maybe he thinks, well, I can't load the feet and I have to protect them. I always have to do this. And you're thinking, oh no, we need to build up your feet and your everything around the foot and the back, just the whole system. So I'd be like, can I tell you something that's a little bit different than what you've been told before? And I'm really sorry, for saying you can get frustrating when all these people tell you different things. And specifically with the keeping to the 2,000, I'd be like, it's totally fine to back off for a couple of weeks sometimes. you know, but you gave that a really good try. And then the evolution of that is we need to give your feet a reason to adapt, right? And you know this in the past because you told me when you were feeling good or when you played football or whatever it happened to be, like you did this stress on your foot and your back and you got better and it built you up. So we need to do that again. And so I'd just sort of like anytime you have a belief you're challenging in someone, you almost want to acknowledge that, like not acknowledge that isn't the right word, sorry. It's more like you got to find that they already believe that from something in their past. So you're not telling them anything they don't already know. They're like, oh, look, you know that you can do this. Look what you did before. Is that where you're thinking? Like, I don't
Yes,
want to go on a
absolutely. I
tangent.
mean, I think sometimes they come in thinking there's going to be this like magic exercise or this like, if I just do this thing, then, you know, if I do 800 calf raises, that this should help me. And that's just, you know, a conversation that I've had to really have with a lot of people.
Yeah.
You know, that there isn't going to be some magic exercise that is going to fix what is going on.
Yeah. That it'll take time, but you're here and and then that's normal. So it's almost like I like the treatment buffet theory of like this isn't everyone's style of practice. Some people are really like autocratic or like this is what you need to do. This is exactly what's going to happen. And I swear there's people that really respond to that being told exactly, but I don't practice that way. So I'd be more like, hey, this is my thought process with pain. It's really simple. We have to calm shit down and build you back up to do the things that you love. You've done tons of calming down. You've got orthotics, you got boots, you're hardly moving, right? So you've already done that. So now we have to build you up to do the things that you love. So here's our options. What do you want to do with me? Like, are there things that you'd be interested in?
Yeah.
Or like you as a practitioner, this is the other, no one talks about this. It's always my joke. Everyone's like, oh, make it patient-centered. I'm like, what about us? You know, why not therapist-centered? Because I swear that I know I probably give the same 5 exercises to everyone, but I like those ones. And you probably have ones that
I
like
just say walk
you
more.
love. Yeah. So there you go. Like, yeah, and that's great. And so that's it. So sometimes there's this idea of you sell the exercise that you love, and then that infection
Yeah.
that it's contagious, the enthusiasm for it, and then they buy into it and all that stuff. So that'd be wonderful.
Like I think it was pretty interesting with him because he was so afraid to take even like anything over the threshold of 2,000 steps. And then, you know, when we talked to him about just take 2,500, just take
Yeah.
3,000, the shock, he was almost shocked. He's like, I can't believe my foot doesn't hurt more,
Yeah.
you know?
He's gonna do fine. Or like, do you think sometimes uh, I always struggle with just I'm always afraid people think, oh, Greg just told me just to do whatever I wanted. Like, what kind of rehab was that?
Yeah.
So sometimes I'll like with the 2,000 steps, I'll prescribe meaningful activity. I'm like, in the morning, I want you to walk 12 minutes. And at lunchtime, it's 7, you know, like validate it and write it down and make it like prescribing meaningful activity. I want you to go and you know spend 20 minutes at the coffee shop with your friends or something and write as you know because it's easy to prescribe exercise but
Yeah.
prescribing meaningful activity and making it look like a rehab program is harder for people
Yeah, for sure. I had
like
him,
to sell it. Yeah.
I had him on True Coach and I did a 5-minute walk in the morning,
Yeah.
5 minutes at lunch, and 5 minutes at dinner. But
Yeah.
then at the end of the week, I had him, I was like, you need to tell me 3 fun things that you did this week because
Perfect.
he just, I mean, everything was so consumed. His entire identity was consumed with his foot being in his basement. And
Yeah.
at 27 years old, it was just heartbreaking.
Yeah. No kidding. That's the rehab holiday person where I'm like, you need to get away from thinking you need to fix
Yeah.
yourself. You got to start living, man. Yeah, I had a patient tell me, she's like, the best thing he told me was exactly what you said, was to write down the 3 things you were really happy with that you did that day.
Yeah.
And we high-fived. She said that was great. And I walked away and I said to myself, I never told her that, but now I'm going to steal it. I suck as a therapist. The only thing that helped her was the thing that I didn't tell her.
So
Suck,
when,
Lehman.
you know, when patients start talking like this, right? Like you can go down the path was, you know, is it in their head? How do you combat that kind of when the patient's like, is this all in my head?
I, I would ask them like, what do they think, of course, and then
Yeah.
I would say no, like it's always it's still in your foot, it's still your tissue, right? It's the tissue that's sensitive, and then you would say there's all these things that can sensitize your tissue, and I say you know this because when you're not feeling well and you're a little bit sick, I bet your foot's more sore, right? Or, we know that in runners, they're more likely to get stress fractures if they're not sleeping well, or if their diet is subpar and they're underweight. So we just say like, is that just the tissue? No, it's the whole system.
Yeah.
So I think people get that, especially like, when you ask when they feel really bad, like when it's worse, it's often not just mechanical loading.
Yeah.
It's all the things. So I always say, like Peter Saul, it's the tissue and everything that sensitizes it. It's just an easier sell.
Yeah. I mean, I remember when I had some pretty good low back pain, probably like 10 years ago. I was training for my triathlons, but I was also going through a divorce. And I teach this stuff. Yet when I was in it, I could not like wrap my brain around the fact that it could quite possibly be this divorce that was taking me to this and I did all the things that I would never tell my patient to do. I'm like
Yeah.
getting an MRI and I'm, in panic. And the day I signed my divorce papers, I literally was like, he really was a pain in my ass because it literally like that day I was like, wow. And you know, it's so when you're in it, it's so hard, I think, to kind of wrap your brain around some of the stuff, which is why that workbook that you have has been so helpful. Um, I've read that multiple times, not just to give to my patients.
Oh, good, good. You had a high hamstring tendinopathy?
Me,
Yeah.
I had just some chronic low back pain. I do
Oh,
have
okay.
chronic left hamstring tendinopathy,
Yeah.
but it definitely was amped up with my cup was overflowing.
Yeah. Yeah. That's yeah. I like the cup analogy because uh, and
Could you
for those
describe
not
that to
knowing,
those?
yeah.
Because
Sorry, I was just. It's sort of like you are this cup, right? And you have pain when there's all these stressors in your life, and sometimes it's joint osteoarthritis. It's like your diet, when you exercise, you do too much too soon. When you run, 80% of your runs are really fast instead of really slow. Like so it's anything that might you have a history of pain, when you're a kid, so your nervous system might just be a tad sensitized, maybe you have some anxiety, you tend to ruminate on things. So it's anything that might predispose you to pain that goes in the cup. And then when those stressors just get too much, we have pain and the cup overflows. But why I like the cup analogy, what people have to realize is it doesn't have to be empty to be pain-free. You can have a lot of shitty things going on that predispose you to pain and you can still be living well. Either you have less pain or you have no pain, is sort of the idea. That's the cup in a nutshell.
And I think you've mentioned, and correct me if I'm wrong, that gives us multiple ways to treat, right? So you have all these
Yeah.
different kind of opportunities, if
Yeah.
you will, to treat the patient.
That's the idea. But to be honest, I still stay predominantly in the physical world,
Yeah.
just because I think like movement and exercise and meaningful activity and all that stuff is like that people talk about psychosocial stressors, but if the big ones are like fear of movement or something like that, fear you're going to damage that. Yeah, that's a psychological construct, but it's movement professionals I think are still the best people to deal with that because the way you deal with fear, like this person's with their foot, is to start walking again. It's a physical intervention to help the psychological thing. You can't just tell someone they're safe. Like, don't worry about it. Like that's like telling someone to relax. You have to like do physical stuff because your fear is related to physical stuff. Unless someone has like generalized fear or an anxiety, then they should be seeing a psychologist or something like that, or OCD. But if it's anxiety related to physical things, then to me, the intervention is physical.
Yeah.
So I don't.
When they say to you, how much is too much? How am I going to know? So let's say this kid says, well, what if I walk 5,000 steps? How am I going to know? Because we get that question a lot. How do I know when it's too much?
Yeah, we don't. And I'll be super honest, like you might totally flare up because you haven't done this for a while, or you might be fantastic. But even when you have a flare, you haven't done any damage. You just sensitized it. It'll calm back down. And now we know your threshold. This is great. This
Yeah.
is like everything is a test. The intervention is a test. You know, it's just the first assessment takes 2 weeks sometimes. Right. So I fully acknowledge that they can flare, but it's cool.
Right.
That I'm here for you. We'll work around it. We'll take it easy when that happens. We'll do other stuff, and then we know your baseline. It's great.
Yeah, I think addressing that so that they know that before
Yeah,
they're not shocked when they're like, oh shit, what just happened?
yeah, yeah. I like to inoculate, right? That it's totally fine, and then they're prepared for it.
One of the other analogies that I really liked that you have used, and I would love for you to explain to people, is the fire alarm, like the smoke alarm.
Oh, I don't even know if I use that one anymore. What I think,
Like basically, like when the smoke alarm goes off, you just don't know how big the fire is.
oh yeah. That's sort of yeah. It's such a weird message because it's sort of I use it more of the idea we can't always trust what our body tells us. That's sort of the idea. So pain in general isn't a good guide to how bad things are.
Right.
It's just a good guide to how much pain you have, just like a fire alarm, right? It doesn't tell you if the fire is a tiny little spark or if it's lots of smoke or if it's a raging inferno. That would be the idea, right? Which is a weird message because you don't want to tell people don't trust your body, right? Because
Yeah.
we should listen to our body sometimes, but when it comes to pain, it just corrupts things. You can't trust it anymore. You feel tight, you're not tight. You feel out of place, you're totally symmetrical, right?
Right.
It's weird. It's like runners and fatigue. Like you fully sometimes you'll hear people they feel like garbage and then they set a PB and the race feels horrible, but it's still
Yeah.
like their best run ever. Like we can't always trust what we feel. Right. Because that kind of sucks. It's like anxiety, right? Like we regularly overreact. It's cool to be anxious. You should be worried about things. When you have a panic attack, that's just your body doing it too much,
Yeah.
right? And same with pain. It's just dumb sometimes.
Yeah. I think when talking about anxiety, for example, spinning it being like, it's not that we don't want to have any anxiety, being that kind of having this level of anxiety or presence about it. If spinning it to make it into a positive is that means that you care about something, or
Yeah.
that means, and I think that's a good way to look at that, rather than trying to eliminate it completely.
Oh yeah. And some people will talk about pain that way. And I think it's a good message. Like I'm in pain a lot, not a lot of pain, but like all the time there's something. And I've had it since I was a kid.
Yeah.
And I don't think I'm not an unsuccessful physio. It's just that I have no worries about it. Like, oh, I'm really sore in my hip today or my back sore. I'm like, that's fine. That's just pain. Like it doesn't stop anything. Right. And so like understanding that
That's
and
a good
accepting
message
is
right there.
helpful. I think it's huge. I think like for runners or any athlete to acknowledge that it's okay to be sore, you know, that you're going to have these niggles. And for some people, persistent pain, it's like Bronnie Lennox Thompson. I don't even know Bronnie, but I love her. She's an OT out of New Zealand. It's just this idea of like living well with pain. And some people like if you just chased being pain free, it's too consuming.
Yeah.
You know, it's like trying to fall asleep. No one tries to fall asleep. You just fall asleep. But if you try to fall asleep, you're not going to fall asleep.
Right.
And I think pain is a bit like that sometimes. You're always trying to fix yourself. It's just you just think about it more and you make it worse, or at least you have more suffering.
Then you try to run around trying to fix everything, and then the next thing you know, you're not moving at all.
Uh-huh. Yeah. Yeah. I just that should be like a common pain message for people. Like that I think a lot of people don't realize that it's okay not to be pain-free 100% of the time. They think that something's wrong, right? But there's so many people that are okay with that. The problem is we just don't see them as therapists. They don't come in and see us. If you took like a survey, you'd see a shit ton of people who are doing fantastic, right, as athletes, but they regularly have some discomfort.
I like that, living well with pain.
Yeah, it's neat. It's like, I don't know if you know, like the old ergonomics research, this stuff's real old. Like you'll hear of people going into a factory and during an ergonomics program to try to prevent injuries. But then you hear that the injuries increased after the interventions. And the thought there was like, you just drew attention to people's reporting of the regular pain that they had and all of that stuff. You didn't like, and they could actually be doing better, but now they're just reporting it more.
Right.
It's like an old 30-year-old anecdote, which I don't even have a reference for. So maybe someone made it up and now I just repeated it.
Well, I also wanted to get into a little bit of some of the things you've talked about in the running course.
Okay.
One of my favorite videos, and this is, I'm just kind of skimming through it, and I'm a detailed person, so I'm probably going to go back in through this thing multiple times. But that video of the kid jumping over the guy that's standing,
Yeah.
right? And he has like all this valgus, and like,
Yeah.
it's so interesting to me. Because when I teach my courses, I sometimes use the analogy of like a hockey player, when
Yeah.
he's like, or the goalie in particular.
Yeah.
He's like standing in that position for, basically the entire game. And
Yeah.
we keep wanting to say that this is a bad position, but when you see these guys perform, or gals, in this
Yeah.
position, you're like, so just kind of talk to that a little bit, because I think it's I think from people that assess gait, and it's important that this concept of normal, and I know we kind of beat this down, but I just would love to hear it from your perspective.
Yeah. I mean, so it's the idea that I'm gonna be really technical. We actually, I don't know if this got published, but technically Valgus doesn't even exist.
Talk about it.
Like,
This is what
yeah,
I
because
want to hear.
Valgus is supposed to be hip adduction, knee abduction, and hip internal rotation. And why it doesn't exist is really just an illusion, because our knee doesn't really abduct a lot. That means the foot abducts relative to the knee. So anytime I see a paper where they have like 7 degrees of knee abduction, that didn't really happen. It's probably only 1 to 2 degrees. Like, think about it. Like, if you just take your knee and try to have someone do an MCL or LCL stress test,
Doesn't go anywhere.
yeah, it does not move in 5 degrees. So technically, we don't even really do the thing that we say, but whatever. So
No, I
yeah,
love it. That's the kind of shit I love. So talk
yeah,
all.
that's Fraser Phillips stuff. He's been writing that. But anyways, so what we really measure is hip adduction. We should sure do hip, and those goalies definitely do hip adduction. So my thought years ago was like, I remember I was a strength coach for a women's hockey team, and I used to do like the FIFA 11 ACL injury prevention program. And I definitely would tell people, push your knees out when you're landing, push your knees out. I thought that stuff. But then and I know that helped people. And I know that helped prevent injuries. That's what the research would say. But
Yeah.
what's so cool is when you look at the research is you end up not changing those movement patterns in those people in general, but the injury risk still decreased. So
Yeah.
or again, you would see people jumping and they would have this huge amount of valgus or hip adduction, or people running with that. And I'd just be like, if this is so bad, why are so many people doing it and performing at such a high level? Right. That was just my thought process there. And I think that's become really accepted through the years when people have researched it more and more, that it's really not an inherently injurious pattern. Right. And then what I would guess what our rehab programs do is they just make that pattern more stronger and stable, and they just reinforce it. So it's not a bad pattern. You just get good at it. And then that's why people are safe.
Right.
That is, we've been worried about, and we probably shouldn't have been. However, I say that, and I would totally respect people where someone's a run, and I don't practice like this, but it's where someone runs and their knees cave in a lot, and if they run with their knees out, that they can feel better. So I believe that we can have options. It's just such a hard, like, I think Irene Davis would practice that way, like push, at least her old work with Crowell, I guess the name was, but so I would totally recognize that it's one option to do symptom modification to avoid valgus, but it's such a pain in the ass. I'd be like, would you rather do something else, like take shorter steps?
Yeah, I mean, the compliancy is a factor there.
Yeah.
Right? I mean, this like gait biofeedback, and they're like, you need to be on the treadmill for like 10 minutes, and like, who's doing that?
Exactly.
Right?
Yeah. 2 to 3 times a week with all the
Yeah.
feedback. I'm like, no one wants to, and then you're paying like $80 to go in and do it. Yeah, it just
I
seems like
bought
too
this,
much.
like expensive when I was like, I'm going to do all this gait analysis. And I bought all this, like, there's video
Yeah,
cameras everywhere. And there was like this TV where you could run and like, try to get this biofeed. And it was cool.
yeah.
But I'm like, I don't think I've used it twice.
I had one too. It was the 3D kinematics. And people would pay $500 to
Yeah,
do it because I was at a fancy clinic. But then it never informed what I did.
I know.
Like I'm a crook.
Um, so let's see, but when we talk about like hip adduction or like calcaneal eversion, for example. So
Right.
one of the things I know you had mentioned also was when you see someone with excessive calcaneal eversion, you take them more into that range, which I think is something that, some people have been like, well, I see this foot and it's severely everting. I have to get them to invert. Can you talk about that, building resiliency in
Yeah.
changes rather than avoiding them?
That would be the idea. So like instead, that's what I would use the fancy 3D kinematics for. If someone did lots of hip adduction or calcaneal eversion, I'm like, well, listen, you do it. We might as well, it's a simple idea. We might as well prepare you to do it,
Yeah.
right? That you're going to do it no matter what. So, okay, let's make that the best pronating foot ever.
What
And
would be an example of a strategy that you would utilize?
so I take the boring old calf raise, and as you're doing the calf raise, I have people bring their knee inwards, and sometimes the foot just follows along and it goes into calcaneal eversion. Sometimes like that cue doesn't work at all, and their foot just stays rigid even though their knee is in. So then I would say roll onto the inside of your big toe.
Mhm.
Right? Don't let me see your arch, like let the arch go down, and that seems to help. And I'm like, and this is going to feel weird and it's going to be hard on your foot. What other people would do, they would do the classic calf raise and squeeze a ball between the leg. And that's just creating that moment. I'm actually, that's a good start, but I actually don't want just the moment. I want the movement to go in there. And then every now and then I'm like, I don't even know if I need to do this. Maybe just regular old calf raises or running or
Yeah.
hopping on the toes will do the same preparation, but I don't know, people, it's funner.
It's so important, I think, because we, especially for those of us, and I know there's a lot on this that will be listening to this, not to try to, take these positions and get people out of them. I mean, I was in Mexico a couple months ago, and I saw this kid running on the beach, and this is how crazy I am. He had this beautiful running gait, his stride length. I mean, and his footprint though, it looked like he was running on his navicular. Right? And it's hard to run in sand to begin with,
Yeah,
let alone like, and someone looking at his foot could be like, oh my gosh, well, this kid should not be running.
yeah,
And I actually went up to him and we started talking. And, I mean, he was telling me how fast he was and it was just really eye-opening to me that it was just one of those cases where you're like, there's nothing to fix here.
yeah.
Even though, and I always caution people, be careful of what don't be fooled by what you see. In trying to say, well, this kid, we got to get this foot into this different position. And I think in the foot world, it's kind of a thing.
Yeah, yeah. I get it though. That's like the back off sometimes. Like sometimes movements do hurt, so maybe it's worth backing off. But I just have, it's just so hard, like, and it might be worth it for the short term, but people are just going to go back to their movement patterns. So you might as well prepare them for it. Right?
When do you know, like if you're watching someone, right, or you assess them, is there ever a time where you're like, I don't necessarily like what I'm seeing, or I have a feeling that this could, they're starting to report with symptom or whatever, that you would intervene and say, maybe start doing something like this, or do you just not approach?
So I think if in the course, like what I like, because I acknowledge I have lots of uncertainty. I think there's lots of different ways to run, but one of my, like, I guess not principles, but I think variety is good. Yeah, I guess that's what I think. And so, and I think like a lot of people get natural variety in their running because they have a coach who gives them work on a track, and then they run on a trail, and then they run on asphalt, and then they run fast, and they run slow, and then they have different shoes. But then I also would say to someone like, maybe if you normally heel strike, why don't you do 30 seconds every now and then of forefoot striking? Or why don't you run barefoot a little while? Like, so you just, this is sort of this idea. I don't know what has to change, but why don't we just build up the most resilient system that we can? And that's lots of variety. So that's where I would talk to people about. Is that what he meant? Like when I would
Yeah.
think of stepping in and
So
say
like
run
by a
different?
variability then.
Yeah, that would be the idea. That would be like the guiding philosophy there, that like over prepare the system and variability will do that. Or like,
Great. Yeah.
and this isn't about gait, that would be gait. I call them form fartleks. Like, and I like to do it when I run. When I used to run, I'd be like, okay, now I'm gonna do 30 seconds on my forefoot. Now I'm gonna do like 30 seconds of really poppy, sharp stride where it's a short pop, pop, pop. Now I'm gonna do something where my feet are, I didn't really do that one, but my feet wider apart. Or now when I run on the Toronto sidewalks, I'm gonna sort of curl a little bit and go side to side. Urban trailing. I don't know what's it called. So like just playing around with stuff like that. And I just think people do that naturally with coaching, but sometimes maybe we need to force a little bit of variety.
Yeah, I feel like when I first moved out here, probably like 10 years ago, people were still running 5Ks. Nobody runs 5Ks anymore out here.
I love 5Ks.
If you're not doing a 50K or 100 miler, then you're just not really running. And it's really wild. And
oh, that's funny.
It is. The ultra running world is insane out here.
Yeah.
And when you talk to some of these runners about it's okay to walk for a minute or mix it up a little bit.
Yeah.
About this continuous, it's a hard conversation to have. They're just like, I just don't feel right doing that.
Oh, really?
And it's such a good, I don't know if cue is the right word, but I love that variability.
Yeah. And it's just, it's just more fun. That's all I would sell it. I think sometimes with athletes like that, you have to sell things like via performance.
Yeah.
Like that's why the 80-20 rule, I know it's debatable, or polarized training so good, because you could say, listen, you just got to run slower sometimes, man.
Yeah.
You're running too hard all the time. You're like, no, I don't want to. I got to get better. I'm like, no, in fact, this is better for performance. So we're guessing it might be better for injury risk, but we could certainly say, let's sell it via performance.
Right.
That's what's neat with Camille Herron and her style of ultra running, right? She's not a massive mileage hog, and she does multiple runs per day and limits her long run to like 18 miles, even though she'll do 100 miles, 100 milers. And so that's great when you have like super elite people as a model to say, no, you could run less and still do fantastic.
Right. I love that because I think each runner has almost like their own individual kind of course of action, how they do things.
Yeah.
Some are the heavy mileage, some are the less mileage, and to see that variability amongst these elite runners is pretty cool.
And it's nice for us to see. That's often why I'm on Strava, is just to show people, like, look at this elite runner and how slow they run. I just had Rachel Hanna on my podcast, and she's like a 2:32 marathoner.
Yeah.
And I was like, your last slow run, how fast did you run? This is in kilometers. So, okay, I'll convert it to miles for people. And it would have been like almost a 9-minute mile. Right. And when she would race, I think she would do miles, this makes a 5:30 mile. You know what I mean? So like, yeah, I'm like, so she's running slower than the vast majority of 4-hour marathoners. Yet she's a 2:32 marathoner.
Did she do like the majority slow runs, or would she do speed work or tempo work or?
Yeah.
Yeah.
She would follow the polarized model. I wouldn't say all of her easy runs are like a 5:30 kilometer or 9-minute mile, but she would have definitely some of them in there. Right. I don't think, and I think if you look at a lot of Strava, you'll see a lot of elite runners running that slow for their easy runs. It surprises people.
Yes. Strava's gonna I know there's so much information on Strava.
Yeah.
I always say it's gonna be the death of me. That was in my competitive years. Now I don't do that anymore. Okay, I have some more questions here if you don't mind.
Okay.
One of the things that I think you talked about is this flaw really a flaw?
Yeah.
And I just really liked that because it's a great question. Is this flaw really a flaw? And is it something that, we need to try to address? So could you speak to a little bit on that?
Yeah. So so it's really about consuming research. Most of the research, like let's say someone has knee pain.
Yeah.
Okay. Someone will do a biomechanical study and they have EMG equipment because that's what their lab has. So what are they going to measure? EMG stuff. That's how we do research. It's just totally pragmatic. Don't know what to do. So they might find that the VMO is delayed 60 milliseconds when you do a step-up task. So then we'll say, aha, look, when people have knee pain, the VMO is delayed. And then usually that's where the research stops. They just find like a cross-sectional study and they confuse correlation with causation. And they say a delay in research or delay in VMO timing is what's causing knee pain. Or they might kind of say, oh, this is something we need to change. And so what I would say is like, we assume that delay in VMO timing is a barrier to recovery and it needs to be addressed specifically. So the flaw algorithm is just sort of saying, do we have research that shows if you don't change this VMO timing, this person won't recover? That's the most important question to me. And then when you look at the research, you find, oh, you don't have to change that VMO timing. It doesn't correlate with recovery, but most of the time we don't have research in that area. And so what's fantastic with Dr. Cowan and Dr. Crossley, they've realized that through the years. So they used to do all this research on VMO timing, and now they're like, our programs were great. We helped a ton of people, but they weren't helpful because they changed the VMO timing. They're helpful because they progressively loaded the person, and then the person got back to doing the things that they loved. Right. So that's what it's to me. Maybe I'm just choosing research that fits my bias. That's bad. I'm a bad scientist. But like, yes, I am doing that. That's why it's a great study. Right.
I think that's an important concept for people to grasp, though.
Yeah.
That those types of things that we see in the long run is just this progressive loading that's getting these guys better.
Uh-huh. Yeah. And often what we're doing is just quibbling over like details of what the mechanism is.
Right.
Like people will think that I disagree with Stu McGill or something about that on like the spine. And I'm like, I don't really, I'm just quibbling over like academic debates. I like the idea of finding something that hurts in the spine and then teaching someone a different way to move that feels better and keeping them doing the things that they love. And then where the debate would be like, I don't think like it's because it was a disc, or we could never know if it was a disc or something like that, or the disc is wearing away because your spine, flexing your spine. So we have these debates over these little things that don't really matter. Instead, we should just say, well, what is it that was helpful with that approach? And then double down on that.
Yeah, that's correct. When I had my back pain, this is when I was in chiro school.
Yeah.
I took a Stu McGill course when I was there, which would have been 20 years ago.
Yeah.
I don't think I was afraid to flex my spine for probably 5 years. I would literally it was pretty wild.
Yeah.
And I would just wonder, and I don't want to get into that whole round. We could talk about that for hours, but it's pretty interesting how there's still a lot of people talking about the dangers of flexing the spine, which, I just don't.
Yeah, it is really tough. It's a minefield, that area of research. But again, like I'm a movement optimist, which means like for some people, rounding their spine more is the way for them to lift because they feel better.
Yeah.
Fine less because for whatever reason, they do lots of it. It's aggravating and they need to change it up. Or maybe they're working with a coach, and like I still try to teach a neutral deadlift because I think it's better for the hips.
Yeah.
I just think you train your glutes better when you're trying to be stiff. And for the sports I do, that's a good position for me. Like for golf, it's kind of like that's the position you get in. You don't have a lot of spine routing. So why would I train it? But when I do gymnastics, I still do sit-ups because I'm training backflips. And the sit-up is the position you get into all the time. So I just don't have these strong opinions on things. And that's I like to look at people who like we might seem really different and then like, well, what are people doing that's similar across different therapists? And find those common threads. And that's probably like where we want to spend most of our time practicing.
From a research perspective, are there any like who do you love? Like if I'm going to go into PubMed and I want to read some good research, are there any people that you're like, I really like what they're putting out recently? Are there any good kind of research articles or things that you're interested in lately that would be of interest?
It would depend on the topic, but what I like to do is find people who are relatively new researchers and then go read their PhD. Right? Because when with their PhD, they'll have like a 30-page literature review of their topic area. And so they've done all the work for you.
Yeah.
Right. So if, say I'm interested in stretching, like this is an older PhD, but it's Marie Maltebook. I think she's Swedish or Norwegian. And she just wrote a great static stretching treatise on what it does biomechanically and all that stuff. Or I would and then I would find someone like she would cite Blazevich, Tony Blazevich, and then I'd go read all of Blazevich stuff. Or if I'm learning about tendons, it's like it's almost geographical. So you can start with the Australians with Ebony Rio and Jill Cook and Miles Murphy and all of those people. But then what you want to do is say, okay, they're saying this thing. Is there another research group that I'm not reading that might be saying something different? And then I would think about like Sebastian Bohm and Mersman. I think they're German. I don't know, they're European. And so I'd go read all of their stuff. Right. So I just always like read one because everyone kind of researches together. So read that group and then go try to find someone else saying something different. So don't just rely on them. What's that?
I need to quit my job. I need more hours in the day.
So this is the thing. I'm like, I like reading research and but I think I wrote a blog post on this. I'm like, why staying up to date is totally overrated. I just think like once you find your fundamentals, the research, I don't know, there's pressure to be a researcher to publish a lot, but I don't think it's dramatically changing anything in people's practice.
Yeah.
It's crazy. I know that like I still do it. Like, so every now and then go check on your fundamentals with research and make sure that they're still valid.
Yeah.
But don't give yourself like anxiety, right? Because you feel like you're not, you know what I mean? It's so stressful. Like
I do that to myself.
Yeah, I'm telling you, like every now and then, like say, I just read 20 papers. Did it really change what I do?
Right.
And I don't know. Often if it's changing what you do.
That's such a good question because I mean, you could read, but how much do you take from the paper and make it clinical or bring it into your clinic?
Yeah. I mean, I don't know if it often I think research is helpful because it undoes the wrongs of the past, but that just meant that we read research too soon before and thought it was like the transverse abdominal stuff. Like now people are saying, oh, we don't need to do that type of training. Well, maybe we shouldn't have adopted that philosophy in the first place. Right. It's because we were thinking research was so great.
Yeah.
It's a bit meta.
I was listening to a lecture that Jill Cook did, and it was on tendinopathies, and she took an approach of what not to do rather than what to do. And I kind of liked that from that perspective, rather than you need to do all of this stuff with tendons versus this is what not to do. And I think that can be very educational as well.
It can be. I wrote a blog on that too, where it's like,
blogs.
It's really hard it's the problem with saying things not to do sometimes. Like, especially if you say, don't do this treatment approach.
Yeah.
I have difficulty with that because like what the person will often say is like I believe in heavy loading, and so does Jill Cook. So she might say, heavy loading is the thing that I need to do. And so I get all these patients that come to me, they haven't gotten better because all they've got was manual therapy, dry needling, and like these low load exercises, and they never recovered. I then gave them a heavy loading program and they recovered. And then she might make the conclusion, C, the low load stuff was useless. And you can't say that because you're not seeing all the people that did it, that got better
Yeah.
with that approach and didn't see you. So I always get little sheepish, like saying that thing sucks. And I used to be more aggressive in the past. And I'd be like, can I really say that thing sucks? Like, have people really tested it that well?
Yeah.
It's bonkers that it hasn't. Like, there's a paper by Radonovich where it's heavy loading for Achilles tendinopathy. It's in the course. I don't know if you read it. Heavy loading, medium loading, which is the classic painful eccentrics, and manual therapy. And my bias would be heavy loading. Yeah, it makes sense. And there was no difference between the three groups. We're like, what the hell is going on?
Yeah, I was actually going to bring up, I forget what's, and it might have been that study, but I remember one of them was talking about their patient perception, where they did heavy loading and then like manual therapies. And the patients said that the manual therapies felt better,
Oh, interesting.
and it's, I'll have to find
I
that.
don't know that one.
Um,
Yeah, I don't
but
know.
no, and that's why you don't want to disregard that stuff, because if
No.
manual therapies make them feel better, then why would you not want to do that in addition to what you know is going to help them?
Yeah, and I bet, like, I've worked in lots of manual therapy clinics and I know they help tons of people and wouldn't give a lot of exercises, but I would. But then at the same time, when I would listen to the manual therapist practice, what are they doing really well? Advice on load management.
Yeah.
So they backed off the running and then slowly built back up the running. And that might have been the physical stimulus for the tendon to adapt if we think that the tendon needs to adapt. Manual therapy might have helped with pain, but they still did physical loading. It just wasn't your classic eccentrics or heavy calf raises.
Right. Interesting research on the static stretching too, that you talked about, which I liked.
Yeah, so there's an example of how I use research to go challenge my bias. Because
Yeah.
I was very much against static stretching for a long time. But I realized, and I was still reading the research, I wasn't really reading it with a critical mind. I was reading it to confirm what I thought.
Yeah.
So then one day, like 8 years ago, I was like, all right, pretend you don't know anything, really read the research. And I was like, shit, I gotta update what I think on this.
Starting the research article with saying, I don't know anything, right? And just going
Yeah,
completely, yeah.
yeah.
Reading the research to confirm your biases is always, I'm always like, oh, I love this article. I'm like, well,
Yeah.
of course you do.
That's why people take my course too. They're like, oh, I loved your course. I learned nothing. But you made me feel better about what I do. I'm like,
Right.
good. That happens sometimes. I take those courses as well.
Well, I don't, we're coming up on the hour here. So we always end with 3 questions.
Okay.
So first question is, if you could give one bit of advice to everybody listening to this call, that could be good clinical advice or anything in general, what would it be?
Oh yeah. So it's related to the research stuff. That's what I always say. Like, you're going to help a lot of people. The doubts that you have, everyone should have them. You don't need to know everything to help everyone. And I would say that a lot of people who are so confident, they're just hiding their doubts, or they're not smart enough to be uncertain enough. Yeah. So give yourself a break. That's what I always say to clinicians.
I love that. It like makes me breathe easier. I always think like the more I think I know, the less I know. And I mean, I come home and I read and it's those days where I'm like, I feel like I don't know anything.
Yeah, I think social media does that. You just feel like bombarded with stuff.
Yeah.
And I think people are accidentally maybe making people feel dumb in order to sell a product. I don't know if they do it on purpose or not, but so don't feel that way.
That's very good. Thank you. One book, any books that you would recommend read, fiction, nonfiction?
I only read fiction. I read like a lot of fantasy stuff. And then I read so much, like it's just on my phone. I don't even know the authors anymore. So who am I reading now? Oh, I'm reading Joe Abercrombie's stuff, his original Grimdark. That's what I'm finishing off.
It's really, I'm laughing because I've only been like a nonfiction person, but recently I've needed to like turn my brain off. So I've started reading fantasy. My cousin told me about these it's like some kind of fairy book and castles, and I never thought in a million years, but I'm like,
What's the series?
it's Sarah Moss. It's like that like Crown of Court and
Okay.
but she has
Yeah, I'll
like
look
a
after it.
series of these books and I'm really enjoying it. And it's very nice to not read
Yeah,
you
totally.
know, something to just turn it down a little bit, you know?
Yeah, that's
I
what I
dig.
do.
All right, last question. This is always my favorite. If you could listen to any album, any music album, what would it be?
What am I listening to now? I just repeat it. So I listen. This is the thing. I listen to the same music and I never know the names of the songs and that stuff. I like the Silver Sun pickups, and then I was like, okay, I gotta update it. So what did I do the other day? Was I did that, and then I found people that were like that. So what am I reading? What am I listening? No, this is new stuff. Paramore and Nothing But Thieves. That's what I'm trying to to listen to. So
The
that's not
Silver
really any
Sun
album, but
Pickups.
I like Silver Sun pickups and that
What's
type of
that one?
stuff.
I love that. Well, there's a song from the Silver Sun Pickups that I just love. It's probably one of their most popular songs. What the
A
hell?
Lazy Eye
Lazy,
probably
yeah, yeah.
the most pop first one. Yeah,
Yeah, that's they've been out for a while.
yeah, I know.
I
I
love that.
still listen to
I'm
them.
gonna listen to that today. Thank you. Very
Yeah,
little refresher back. All right. Well, thank you so much. I was really looking forward to this. I know you're busy. I'm very grateful for your time. For those of you, like I said, I think your website, greglehman.ca,
yeah,
right? That workbook I have been seriously giving to my patients and it has helped so much. There's a lot of information in there. And I think your analogies and how you've been able to communicate that has been extremely beneficial, especially in the foot world where people can come in with a lot of misinformation. And it's really helped me. So thank you. So for those of you who have not seen that, please check out that workbook. And then you have the two courses, right? The Running Resiliency and the Reconciling Biomechanics, the online courses.
yeah. And we do them in person too. But
Oh
yeah.
yeah, you have a bunch of live courses too. Where are you next? Do you want to come to Colorado?
Where am I? Next week I'm in Sweden, and then Surrey in the UK. I don't remember when I'm next in the States. No idea.
Booked up this year. Are you booking for 2025? Let me stop the
Yeah.
because nobody really needs to.